I'm very pleased here to present you on behalf of my Chinese colleague to present our work on low-dose prophylaxis. My title today is Benefits of Low-Dose Prophylaxis in the Treatment of Hemophilia, focused on model in China. I'm from Beijing Children's Hospital, Hematology Oncology Center, also the pediatric hemophilia comprehensive care team. We continue to do our low-dose prophylaxis in 2007. What? Okay. 2007. At that period of time, that is, as all you know, that the cost concentrates, also the shortage of the product. The hemophilia kids treated for the joint bleeding is on-demand only. Also, at that moment, they also use the suboptimal, also delay, also even some of them don't treat anything. So here is one of the survey from our hospital that is enrolled 213 patients. Here you can see during the school age 6 to 9, majority of them, more than 90% of them, have suffered with bleeding, joint bleeding. And also, we can find is there more than 90% of them also have arthropathy. Also, surprises that is half of them, more than half of them is also the multi-arthropathy. So that is at that moment, a crisis is doming over, estimated more than 30,000 severe and moderate hemophilia boys for joint damage and disability. So that is a crisis in care for hemophilia boy at the moment. So we think that initial therapy urgent needed. Even we have a shortage of the many of the also the product. At that moment, we conduct the first pilot study. That is the short-term duration, that just 3 months. That is low-dose prophylaxis. For hemophilia A, we use the 10 units per kilo twice a week. For hemophilia B, we use the 20 units per kilo once a week. So that is the result encourages, that is confirmed. 80% of the reduction of joint bleeding and quality improvement compared to the on-demand treatment. Encourages at that moment with the with the first pilot study. So at that moment, we realized that is a high priority. We want to conduct low-dose prophylaxis in China to stop bleeding and to stop the progression of the arthropathy and also the disability. So we conduct during 2007 to 2015. There is during our hospital and other adult hospital and also the pediatric workshop, we conduct 11 clinical study. This study is 5 published in English journal and 6 in Chinese journal. All 9 studies on children. 4 pilot study, 3 is short and 1 are long-term, and 2 long-term escalating low-dose study and 1 on primary low-dose study and 1 on intracranial hemorrhage and low-dose prophylaxis. 2 studies on adult. So from the early age that during 2011 to 2013, we have 4 low-dose prophylaxis, that is including hemophilia A and hemophilia B, moderate and severe patient, that is nearly to more than 100 patients. Here you can see from the reduction of the bleeding that is around 70 to 83% of the compared to the on-demand treatment. Also, we can control the bleeding to very, very low. But even they proven evidence of 18% of reduction in joint bleeding compared to the on-demand treatment. And also they have a very good improvement in school attendance and daily activity. They also, you can see here, they also have some joint bleeding remained very high. That is show us in our slide, that is 0.32 to 0.9. That equal to 10, maybe 10 joint bleeding. That is that means some patients need to escalating. So the first escalating dose that is we launched in our hospital, that is 6 severe hemophilia A age, average age is 9.6 years old. This patient is from step 1. That step 1 we use the low dose, that is 10 units per kilo two times a week, then to another step 2, that is 10 units per kilo 3 times a week. So from here you can see the reduction of the joint bleeding and target joint bleeding is significant compared to the step 1. But another thing shows us very important, that is even with the low dose here in step 1 in the left column, that you can see the, some progression of the joint function and the joint structure is existed. That means if we use a very low dose, some patient could not stop the joint damage. So even we transfer to the 3 times a week, that shows us with a very good improvement of quality of life. They may be stop the progression of the joint damage. That is, we use the Jablow score at that moment and Parsons score. It stay there. So another one that is for severe hemophilia A, age is more older. That is around 11-year-old. Here we use the low dose, then we to 3 times a week low dose. Then this patient at that moment, they don't have a lot of money, so they choose that is every day to do. So here you can see the duration of the time is very long. So, but the result is very good. If they go to the everyday treatment, there is very good. So you can see also the factor consumption is not so high. It's around 1,050 to is less than 2,000, the majority of them. So for low-dose prophylaxis, we also conduct one primary prophylaxis study that is enrolled 19 patients in our center. That is, all these patients is 1.8-year-old average age. Also based on the individualized dosing by bleeding patterns. That means 3 bleeding in the same joint in the consecutive 3 months and 5 joint bleeding in any time we escalate it. So step 1 is 16. Step 1 is 16 units per kilo once a week or 2 times a week. Step 2 is we escalate it to 3 times a week. Then step 3 maybe near to the normal. That is also that one. So low-dose prophylaxis also shows very effective. During this, we also can see that this study is more than 3 years. And all you see that is just from all these 19 patients, just 8 escalated. 4 of them is escalated 2 times, and 4 of them just 1 time. So that is mean low-dose prophylaxis is effective in primary prophylaxis, but individualized escalating dose treatment are required. So that is our solution. Another very big cohort of the study, that is one retrospective study on use recombinant factor 8 in low-dose prophylaxis in severe hemophilia A in China. That study is a survey, multi-center survey study, survey that is 2007 to 2013. 2013 to the patient who is used coordinate. So totally that is 183 patients enrolled, but just 57 analyzable. So the range is 0.4 to 17. So here you can see all this patient is divided into primary, secondary, and tertiary prophylaxis. It is not make us surprised that it is very good success in primary prophylaxis, but not so good, you can see here, not so good in tertiary prophylaxis. Maybe they exist the damage of the joint. So all this work, we must have some assessment. So this assessment must be international, must be very exactly. That is just based on the China-Canada collaboration work group. This China-Canada collaboration working group established in 2007. The goal of this collaboration work is to share acknowledgement, expertise, and resources for training and support clinical and research hemophilia care developed in China. So the main member in China from China part is from TCNC. That means Hemophilia Treat Center Collaboration Network. Include Dr. Jim Sun from Nanfang Hospital, and Li Xiachen from PUMC, and myself from Beijing Children's Hospital. Then the three member from the Canada part, that is Dr. Blanchett from Toronto, and Manchu Pung from Calgary, and Dr. Kong Hong Luk from Ottawa. So what we do, we collaboration to develop, to establish the cost culture of adoption and training of IPIC assessment and study monitoring tour to China. So firstly, we established 2009 for HJHS in China. And then in 2012, we established the chocolate Chinese version. Then in 2015 and 2017, we established the imaging, that is ultrasound and MRI. Then we do the coagulation and PK testing. By 2016, multidisciplinary professional at Beijing Children's Hospital and Nanfang and selected HTC were trained. One publication was presented by Dr. Luke last the WFH World Congress. That title, that is Successful 9-Year Journey by a China-Canada Professional Group to Transfer Current Hemophilia Assessment Tour from Canada to Advanced Pediatric Hemophilia Care in China. So with all this very good technique, we do the first things as that is individualized PK-driven tailored prophylaxis practice in China. That is pilot study we launched in 2015 January to 2016 May. Inclusion criteria, that is age from 5 to 16 years, and all of them is hemophilia A, severe, and with one or more target joint, and more than 50 exposure days without the inhibitor, and all of them use the original prophylaxis. Then according to the PK test, we calculate the hour that factor 8 level less than 1% during 1 week. That is during a 1 year study period. They divided in 2 parts. One part is phase 1. Phase 1 is 6 months, use prophylaxis according to their original prophylaxis. At that moment, majority of them is low-dose prophylaxis. Then in phase 2, we escalate. We into the another part, 6 months. We divided 2 groups. To do a modified prophylaxis according to their tailored criteria. We divided them from PK tailored group and maintain group. Then we at the end of the study, we compared the ABR, HABR, infusion frequency, and consumption factor consumption. So what means tailored? Everyone will know that is just at that moment in China, do PK tailored, do PK driven prophylaxis or even more expensive in China. So we choose, everyone know, remember Collins' research is very clear. So you can see here, just 1 week, during 1 week, that is if we inside 30 hours, maybe that is predictive bleeding per year is also very low. So our tailored mean that is factor 8 less than 1% hours per week. That is if they less than 30 hours, we let them to the maintain group. Then they larger than 30 hours, we let them into the PK group. Also, at that moment, we could not increase the dose. At that moment, we increased infusion frequency instead of increasing the dosage. So here, 15 patients enrolled in this study, and you can see we divide them into 8 in the PK tailored prophylaxis, another is 7 is in the maintain. All this baseline is comparable. So here we just show you how we to do. Here, for example, in the first patient, so here you can see this patient is the hour per week is 100. So they use the low dose. Here is very low. This patient is 6 months year old. Then we transfer to the 3 times a week. But another thing, if a patient here, you can see this patient is also have a very long hour, more than 30 hours, but this patient without any bleeding, so we still let them in the maintain group. So the result after 6 months shows us that is phase 1, phase 2, also ABR and AJBR is increased very significantly. Also, you can see here the factor consumption is just around 2,000. Also, that's okay. That's exactly. Also, the infusion frequency is great, but it's 180.5. So another analysis, we used all this assessment tool, that is Chinese Hemophilia Individualized Prophylaxis study, our CHIP study. That is objective is to investigate the efficacy of an individualized dose escalating prophylaxis protocol in young boy with severe hemophilia A in China. That is a prospective study, and also 2 major pediatric hemophilia treatment centers in China enrolled. So our including criteria, that is boy is severe hemophilia A, the factor less than 2%, and age is very young, before school, that is 1 to 7 year old, and without inhibitor more than 50 exposure day. And also in this study, we enrolled a patient with 1 bleeding history in the around 6 index joint. So at that moment, we used the dose escalating criteria that is combined. There's a systematic system. So here, as everyone you know, that is now to assessment to the prophylaxis good is not good. We could not just use the bleeding phenotype. Maybe the other things that is imaging bone, that is joint structure and joint function also maybe give some information. So we combine these 2 together. We use bleeding episode and also imaging. We use ultrasound, and also we use the joint function. We use HGHS together. Each 3 months we evaluate it. So if the score is more than 2, we think that is treatment not enough. We escalate it for the patient. So the first stage of escalating is 10 to 15 units per kilo, 2 times a week. Then if not enough, we step to step 2. We escalate it to step 2, that is 3 times a week. Then to step 3, that is 15 to 20 units per kilo, 3 times a week. Then to step 4, that is 20 to 25 units per kilo every other day. So here we at the moment just a week before I came from China, that is 30 patients completed study with mean age is 4.8 year old. That is on entry. That is MSK assessment show a total of 18 boys with 19 touchy joint. Also after 1 year study period, you can see the results show us is very good. So just so you can see 10 to 12 months, that is total bleeding is, average total bleeding is 6.9. 6.8, and AJBR is 2.4, and ATJBR is 0.8. So you can see that his decrease from the joint bleeding is excellent. How they escalating is another point of question. So you can see just 1 year, we have 23 patients. That means 7 patients never escalated. Just 23 patients is experience 40 dose escalation. So here you can see that is just 21. That means 52%. 52% of them just based on the joint bleeding phenotype to escalate it. The other 40, more than 48 patients, that is according to the joint function and the joint structure, and also 12.5% just because of the HJS also ultrasound. So that is the time they escalated. So you can see maybe you can find some regular that is more than 40% of them is escalated very early. That is in the 1 to 3rd month, then to 2 to 6 months, then to 7 to 9 months. Just 10% of them is escalated in 10 to 12 months. There, after 1 year, we conduct our study that is demonstrated as that is 23% of them still in the step 1, and 34 in step 2, and 30 in step 3, and 13 in step 4. So here we can see from this very interesting number that is, you can see 7 patients, they still in the low-dose prophylaxis, but 2/3 of them is in the step 1, step 2. That means intermediate dose here. Then you can see in the total 12 months, that is the number of the bleeding that is control less than 3. Also, you can see from here that is for step 1, step 2, step 3, that factor consumption is less than 2,000. Maybe that is good question. That good question, also a good result. Also, we have all of you maybe worry about how about joint function and joint structure. Here we show you as our preliminary result. That is for HHS 77% of no change with slight improvement. Chocolate is a slight improvement score, and also encourages as 12 out of 19 touched joint were disclassified, and no new touched joint occurred on this study. Also, MRI, no change or slight improvement in 15. Also, ultrasound, 92%, no change or slight improvement. But all this result will be rechecked and reconfirmed later. So the conclusion from the CHIPS that shows significant reduction in joint bleeding with touched joint achieving the greatest benefits. A great cost saving achieved as 87% of patients were good controlled in bleeding using less than 2,000 units per kilo per year compared to the Netherlands and normal low-dose prophylaxis. The dose escalating demonstrated heterogeneous response of the severe hemophilia A boy in China, and about 55% were controlled using low-dose step 1 and step 2 regime after 12 months observation. 45 of the patients required higher dose escalation, but this study is a limitation, just this too short. We need to longer-term study to verify our result. This study using a dose escalating score system to include adding HHS ultrasound examination to bleeding pattern is a unique feature in this study. So all our low-dose prophylaxis, our work is summary in this paper. It published last year. Here, I will show you that is the left one is the photo summer camp in 2008. You can see everyone, well, they wear chair and they stay at the chair. But that another photo, that is summer camp in 2017, that is 10 years. So you can very significant see that is 10 years achievement with low-dose prophylaxis in China are obvious. So low-dose prophylaxis is evidence-based, cost-effective prophylaxis treatment benefiting hemophilia boy in China. However, more work needs to be done to overcome the barriers in practice by education of patients and families to value and acceptance of prophylaxis and professional training to build multidisciplinary care at many of the HTC in China. To building on the work done over the past 10 years and very good support from the stakeholder, WFH, and collaboration from Canada, China is well positioned and committed to conduct more longer studies and groundbreaking research to optimize the cost-effective prophylaxis treatment befitting the hemophilia boy in China and other developing countries. Here, many thanks for our team, comprehensive team. Also, many thanks for HTC-NC. And also, many thanks for Dr. Luke from Ottawa and Dr. Mentri Pung from Calgary and Dr. Blanchett. Also, very thanks for our IPSC members. So also, thank you for your attention.